Very, very, very good morning to everyone. Hello. You guys sound so good, so much better than yesterday morning. Oh my goodness. We've been through such a journey. Starting from yesterday, if this slides will move for me. Starting from yesterday when we started out, maybe a bit tentative, I asked you on Friday night how many of you had whether this was your first time, and definitely there was a lot of you. And we've gotten you from talking about problems, to pitching, to really working in groups to break it down, build it up, and make it better. Give yourselves a big round of applause. I'm so proud of you. This has been such an awesome weekend. So now we're going to go through about an hour or so of the final presentations. I'd just like to walk through with you what that's going to look like. It's my pleasure to introduce our 4 judges who are with us today. Larry, please stand up that people may know you. He's retired from the University of Montana, where he's the Director of Western Area Health Education. Thank you very much, Larry. Diane is the founder and CEO of American Rural. Leslie is the CEO and co-founder of CostCare. And finally, Denise Trader. She's the CEO of Frontier Rural Health Network. Please give our judges a big warm of applause. So the judging criteria is actually very broad and fairly simple. First, the judges are going to look at what's the problem you're solving, how well does your team understand this problem. Secondly, the solution. Have you addressed this problem? Is the solution innovative and feasible? And finally, your pitch. We've seen you practice. You're going to be great. Just go with it. Prizes. Molly touched a bit on this yesterday. Just to recount, there's a first prize and second prize that the judges will pick out. And we need you to pay attention. I know you're worried about your pitches, but this prize is for you. This prize is the crowd favorite, and at the end of all the final presentations, you get to vote and choose who you think deserves this prize.
So the crowd favorite also be first or second? Or
one prize, one crowd favorite prize. One crowd favorite prize. We'll do it next time, right? Do it next time. So presentations will be 5 minutes. Please look at Molly, a colleague from MIT Hacking Medicine. She is going to tell you, how much time you have left, just so we can be respectful of everyone's time and wrap up as necessary. Molly's here. Molly, stand up. You're very important today.
Sorry, it's just the teams that need to see the sign. Just sense the time.
Yes. So if you're presenting up here, I know it's easy to ignore her, but she's going to flash you her brightest smile and tell you really nicely how much time you have left. Then we'll graciously applaud you off. The judges will have 2 minutes of Q&A, and then we'll move on to the next team. So, order of final presentations. We have swapped Grand Roundup with We Care You Count, and these presentation lineups are also on the side, so you can refer to it as the presentations go on. We'd love it if you're the next presentation, for example, when Grand Roundup starts, if Got Joy, you could be on deck and be by the side to be ready to present after they're done. That would be awesome. Maybe we can continue with that throughout. That will really help this final presentations move along. So, without further ado, it is my pleasure to present our first presentation of this morning, Grand Roundup. Woo!
Yeah, we're gonna start at this end of our group, actually.
Paula Perchetta,
Ginny Porter,
Marjorie Erdman,
Sarah Gray,
Samantha Davis,
Sarah Rice,
Rebecca Kellenberg.
And that's all the Mouseketeers. Let's hear it for them. And I'm Gabe Charbonneau. Okay, so is the clock starting? Awesome. So what if we told you that this weekend we came up with a solution that can actually save lives? That's exactly what we think we've done with Team Grand Roundup, and we're super excited to show it to you. Roundup is a play on words between the idea of Grand Rounds, and because we live in Montana, we have a particular enjoyment for the concept of a roundup. So let us tell you, first of all, what the problem is that we're aiming to solve. Rural healthcare providers are isolated. We don't have the same opportunities that people do in cities to connect with one another, to rub elbows with a colleague down the hall nearly as much from different kinds of specialties or different interests or even just different ideas. That's not accessible to us in the same way, so that's a problem. The second thing that we are interested in is a problem across healthcare, but we think that we want to take a focus on that with our group, which is the wellness and the health of our rural healthcare providers. So we believe that if we focus on narrowing the space between communities that are far spread apart and rural providers that are far apart in distance, and we focus on improving the health and wellness of those providers, that actually we can improve outcomes in medical care. And we actually believe that we can impact population health that way by starting at that point. We actually this weekend created a website. We're super excited to show it to you guys. We own the domain, grandroundup.com. It was open and just by Kismet. Yep. This is a snapshot of it right here, and it's kind of a Facebook for rural healthcare providers. I want to stress that this is interdisciplinary. This is not just doctors. This is for massage therapists. It is for physical therapists. It is for chiropractors. It is for anyone who practices rural medicine and who is isolated from their peers and who wants to share great ideas with the person down the road who can support them and help them. There's lots of things we talked about, which I cannot talk about in 5 minutes, no way. But when we get to show you the website, we'll tell you about kind of how we brainstormed what would be most useful. Our first customer is us. We made this because we decided this is something that we need. And that's part of why we're so excited about it. And I think I'm going to go ahead to the next. So this is how we'll begin. We'll start small. Invitations. Like, I know Kirk, he's in my office. I'll start with him and say, hey, Kirk, like, let's try this out between ourselves. Let's see if our buddy down the road in Hamilton, Brett Heath, wants to be on the group with us. And we'll start to have a dialogue and find out what our needs are and if we can share things with one another that we weren't able to as easily by having this online presence. And we'll start in the Bitterroot. We'll spread through Montana, and from there, well, we have big hopes. Next steps for Grand Roundup, we want to recruit a pilot group. We would love to win because we want to use the prize money to actually make this happen, to get it started off the ground. We actually have someone in our group who is doing public health work and has some room for a project, and who has a fiance who is in IT who could potentially support this website. So we'd love to get it off the ground. We want to think about incorporating CME. That's part of our business model, which I would love to tell more details about, but just can't. But we think that CME is important, and we want to incorporate it in our site. There's no more slides because the most important part is a personal story for me. When I moved here, we moved from Spokane. It was a big city, and I had lots of connections, and it was really daunting moving to a small community. And one of the things that I will never forget is I walked into one of our first provider forums that Providence had, and there was a doctor that came up to me, and he was very kind and warm, and he came up and he said, hi, I'm Rob Downey, and I'm a family doctor down the road from you. Here's my cell phone number. If you need anything, you can call me anytime. And from that moment, I just felt like I was safe in a way that I wasn't before, that I had a resource that I just knew could help me and wanted to help me. And we want this website to facilitate things like that happening. We want to connect people with others who will make their rural clinics feel closer together. And we want this community of great rural practice to be more connected. And technology now has evolved to a point where we believe we can make that happen. We're excited to make it happen. We really want to show you our demo. Thank you for having us. I forgot about questions.
Thank you. I agree this is a real problem. Tell us about the ongoing funding or financing. Who's going to pay for this?
Sure. I'll speak to that. So, yeah, our $725 might not take it for a super long time, but we're pretty lean at this point. So, I mean, we already have a website and we haven't paid a dime. Well, actually, we paid $2. Somebody did. Terry paid $2. So CME is I think our most promising model. We would really love to take a focus on provider wellness and have some incorporated courses about maybe you're going to learn mindfulness. Maybe you're going to learn things about self-care and getting started in an exercise program for you as a provider. I mean, whatever the topic is that's important, we want to use evidence-based stuff on our site where people will come and they will learn about it. And actually, we want to have sort of a leveling system where you get rewarded for progressing with your own wellness as you engage with the site. So, and you don't have to pay to participate. You don't have to pay to take the CME. If you want CME credit for those things, then you pay. And I think that we want to make it totally low barrier for people to engage with it and come up with some kind of a sustainable funding model. We thought about subscription services. I mean, we're kind of open. Part of this is we want to really make sure that this is a need and that people want to engage with it and ask them what they want. So part of our dialogue with our community is going to be, how do you want to pay for this? But we think CME is a great start.
Are there existing networks that you can plug into to gain access to your customer targets, like hospital networks and stuff like that?
Just stay up here. Sure. I mean, I think because this is such a grassroots effort that we're coming up with, we really envision it being that it maybe even starts with me and people that I know. And it's like I invite 5 people, and then if it's valuable, they invite 5 or 10 people, and we keep kind of seeking feedback and growing from there. I mean, certainly the hospital is a huge network. So we see lots of opportunities for how to grow it. What we really want to do is make sure that it maintains the spirit and the quality, and so we really want to actually grow it slowly and carefully at first and make sure we're actually achieving our goal of making it be that valuable product that we envision.
Thank you so much, Grand Roundup.
Thank you.
Got Joy, you're up on deck. And smooth moves. If you could be prepared by the side, that would be great.
Louise Harvey.
Mackenzie Burns.
Chris Forstar.
Janelle Davenport.
Brian Wilson.
Pamela Longmire.
Kurt Cruz. Let me make sure the cable's plugged in all the way. Thanks for being here. My name is Kurt Cruz. Our question and the product that we would like to pitch to you today is actually joyfulness. Why joy? We believe that joyfulness is valuable in and of itself, and we want to create more of it. I'd like a show of hands. I'd like everybody to first start by raising their hand, please. Now I'd like everybody that doesn't want to be here to put your hand down. Exactly. I want you to keep your hands up. This is critical. Now, I want everybody from right here over to put your hands down. 60% of physicians today, if they just had enough money, would quit their jobs. That is the problem we're trying to solve. You guys can stay at work and keep your hands up. That's fine. 60% of physicians would quit if they just had enough money. Oh my gosh, that's a big deal. From my own life as a family doctor, I have the privilege of practicing with very good people. One of them just spoke, actually. But I know that when I am down, when I am burned out, when I am troubled, when I look at my partners and see how exhausted they are, we give worse medicine, we pay attention less, we have less patient satisfaction, we have worse outcomes when we're not just joyful. I'm a better person, better doctor, better father, and better husband when I'm joyful. So that is what we're trying to sell to you today, is joyfulness.
So what are the secondary benefits of being a joyful healthcare provider? One is increased employee retention.
Increased quality of care provided. Increased productivity.
Increased patient satisfaction. Better revenue generation.
Decreased stress.
Increased determination of the correct diagnosis.
So I think probably most folks here who've worked in a healthcare setting have gone through a flavor of the month type of program. Usually those programs are good, good ideas to begin with, but they require a lot of executive engagement, and they're already probably overburdened, and it requires a lot of staff buy-in who are also overburdened. So providing that extra work to be able to take on some new program to improve satisfaction or whatever the case might be is tough. Additionally, a lot of times those fall by the wayside, and then bitterness develops, and that staff doesn't necessarily want to participate in the next flavor of the month that comes around. So our program's different. We don't want that top-down infrastructure. We have a different setup.
And how our program is different is that it's bottom-up. It's side-in. It's not top-down. It's not your boss saying, you need to do this because you need to be happier. It's sustainable, and it's adaptable to anybody in the healthcare team, from physicians to nurses to environmental health staff. It's adaptable to anybody. It's grassroots beginnings. It's the individuals, the team members saying, I want to be joyful at work. I want to come back to work and be happy. And what we offer is templates.
Part of what we've realized with joyfulness, with happiness in general, is that it is actually a skill set to be learned and not something that you just get from somewhere else. And so we've actually developed 2 meeting templates, an initial meeting template which sets up kind of the bylaws for how to have a joyfulness and a self-focused meeting, and then a follow-up template to help people do that. This is free open source material. We just want to sell you joy, and it doesn't cost anything. We also feel that it gives people a launching point. How do you get happier is probably one of the most asked questions of humanity.
Okay, in addition to the templates, part of the launching point is just this poster. Got joy? Want joy? We would like people to post this in their facilities, and you could even just have this and use this as your meeting. Why do we want joy? Why do you want joy? What brings joy to your workplace? How do we achieve more joy in this workplace? Who brought me joy today? And who did I bring joy today? Who was I kind to? Who did I value? And can we laugh out loud? This is a mechanism for infection. We want to infect everyone with joy, and we're going to get this out through email. We already have the ability to get it out, mass email, to several states. This is an infection that will continue.
So, this is the Happy German. We want to have you all practice smiling, and changed people change lives.
So we actually physically want everybody to smile for 30 seconds because it's been shown to actually make you more joyful. This is not a joke. If you cannot smile, you are allowed to take a pencil or a pen and hold it in your hand. Ready? Go. Go.
Keep smiling.
You can borrow my pen. You still have 15 seconds. And look, you're so happy you don't even tell us wrong. Okay, you can be sad here.
Judges, any questions?
So you guys said you had mechanisms to get this out to different states and everybody else, but I know it's a grassroots effort, bottom up, side in. How do you propose to have people actually use this and implement it? And using the poster still requires a little bit of buy-in from your administrative level. So do you have a plan that you propose to get that going to?
Several of us might want to address this. This is something that we have discussed. I'm part of Mountain Pacific Quality Health. I go into facilities, other employees at Mountain Pacific, we go into facilities and we offer free materials, and that's really important. We want to keep this no cost, and so we do have the means to get into the facilities and to encourage people to do it, and to have it start where somebody in one department might start it, the joy goes up, the sustainability goes up, and it spreads, and we really want to push infection.
I think one of the key things too, if there's the person who wants to pick this up and drive it and own it, I mean, they're the right person to be doing this. And if they can create proof of concept within their work group, and then other people in their facility, including the leadership, can see the benefit, and then allow that to spread, if you will. That's kind of our take on that. Other questions? Yeah.
Statistically, in the clinic setting, like Kirk said, 60% of physicians would walk away, which, it's just a heartbreaker. Have there been, are there a top 3 items that are bringing that joy down or anything like that have been published? Because I haven't looked at that, so I'm just curious.
So one of the things that you discover quickly in medicine is that everybody's different. Everybody actually wants to be different, and that's okay. So part of our templates, actually the first part of the meeting template is developing a safe place. The second piece of the template is defining 3 things for each person which bring them more joy in their life. The next step is 3 things that take away joy in their life. And then they develop strategies to increase number 1 and decrease number 2. So it really is an adaptable template, which is key. It's part of the problem with top-down. So the ownership is really key, as Brian said, because you need somebody that this actually starts a fire under them. Otherwise, it's kind of useless. So we really toyed with words, and infection is the right word. We want someone to get febrile, right? We want shaking chills. Yeah. So that's kind of how we look at that. And that's what those templates are. We wanted to put them up there, but we showed you the 2 pieces of paper that we did our homework.
Deal.
Thank you so much, Got Joy. Next up, we have Smooth Moves, and Laura, please be on deck.
Lori Ward. Teresa Ormseth.
Kevin Larson.
Laura Chrismore.
Ryan Doherty.
Brad Robinson.
Jay McKiernan.
And Desidy Clark Worst. Not the best, not the worst.
Thank you for having us. We are here to talk about patient care transitions. What is the problem? Our problem starts with inefficient process loop of patient care transitions from critical access hospitals to the regional hospitals, back to the critical access hospitals, and to the community.
Meet Rachel readmission. She was transferred from our critical access hospital to the nearest regional hospital for congestive heart failure and diabetes. In addition to these chronic conditions, Rachel readmissions also has a history of bipolar disorder. Rachel readmission was treated and discharged home. Her neighbor was able to provide transportation home, as Rachel readmission does not drive. Rachel readmissions lives alone with 20 cats. She has no family in the area. Rachel readmission's discharge instructions included a follow-up appointment with her primary care physician. Rachel readmission is unable to make this appointment due to the fact that her neighbor is away on vacation. This behavioral pattern is not new to Rachel readmission or the local emergency department. Rachel has a known history of lack of self-care, not taking medications correctly, and not eating correctly. Upon her neighbor's return from vacation, he decides to check on Rachel readmission and finds her unresponsive on the floor. He calls an ambulance to transport her to the critical access hospital. Due to the seriousness of her condition, the emergency department physician decides transport to the regional center is needed, and the cycle begins again.
As you can see, the system doesn't work very well. So what we're showing in our current value stream map here is that Rachel readmission actually went through the system, okay, getting to the regional hospital. But because she didn't have adequate transition care back, she ended up back in an ED, back to a critical access hospital, and became Rachel readmission, a readmission back to the regional hospital.
The solution for this problem is a 3-pronged approach. One involving the patient, the family, the provider, and the community resources. Critical one is a care coordinator at the critical access hospital who starts this process from the beginning. Secondly is the ability for providers to communicate to each other directly and develop a stronger relationship. The third is an IT piece that allows that communication to take place. Our future state map would be one in which, from the beginning, that process is coordinated well by the coordinator, the care coordinator at the critical access hospital, so that by the time they actually get to the regional hospital, the process is already created so that their transition back to either the critical access hospital for a swing bed stay or back to the community is coordinated well.
How are we going to pay for this? There's two components when you look at it to be paid for. One is the care coordinator and the other is the IT piece, which is their tool. So we have 5 potential sources to tap into here. First off, we have grants. We do believe we need to jumpstart this thing, and so a grant could be used just for education and outreach to jumpstart it and get people engaged and to get them to buy in. Next, we can tap into what's already available, which is the CPT code that you can bill for via Medicare, so that could be used by care coordinators. Third would be some type of sponsorships. Ideally, insurance companies and potentially anybody who really has an incentive to want to decrease these costs. The next one would be government. What can we do here in the state of Montana? Well, I think it'd be a great idea to advocate for a Medicaid billing code in addition to the Medicare one. I understand that to be something that can be locally affected. Also, on the government level, we can possibly have an administrative rule that would enforce this. And lastly, providers potentially paying, but if they're going to be paying, we want it to be scalable, flexible, and affordable.
Who benefits? First off, primarily the patient. Patient has much better coordinated care and reduces their need for a readmission. Secondly, our regional hospital financially benefits because they have fewer readmissions. And our critical access hospital benefits because of increased swing bed stays. Our community is also benefiting because of other services that could be brought into the process for that return home.
So all of this is a safer and better plan for our patients. We do want to focus a little bit on our care coordinator, and an expert care coordinator in these rural areas is really essential. Now, to summarize, this process will significantly improve population health. And here is your Smooth Moves team at work. I just want to go over a little bit about our name and why we picked it. SMOOTH stands for Sustainable, Medically Oriented, Optimized Transitions Home.
Thank you.
So the care coordinator is part of the business, is part of the solution that you're offering, putting together people who will be the care coordinators, or to try and get that job functionality included in your community or in your setting?
The care coordinator needs to be someone who, one, has a medical background, and two, has experience in being able to do this. Won't work without that. That position would be an added expense to the critical access hospital, but would also be paid for by those increased swing bed stays.
So where do I find a care coordinator? What's their credential? How are they educated?
Ideally, but not necessarily absolutely necessary, but ideally would be an RN with care coordination experience. Someone who knows how to do this.
And there could be extenders or supports for that care coordinator position, like community health workers who have been trained, who really are embedded in the community, and they are the backups and the extra arms and hands for that care coordinator.
There's also a care coordination toolkit that has been put together. Do you want to explain a little bit about that?
Well, we have rural access to care, a whole online PDF file on how to do this, and the trouble is that the people in rural areas may not have gotten all of the training, even though people in urban areas may have had that training. So why reinvent the wheel? Why not bring that information back in and then extend it into our community people? The person who is at the critical access hospital in that coordinator role will be of the community, and they will have expertise. So it means drawing someone with experience or growing them from the community.
Great job, Smooth Moves. All right. Next up, we have League of Rural Excellence, or LOR. LOR, fantastic. Primary Care Montana, you're up on deck, right on the side, please.
So my name is Angie. This is Barb, Brandy, and Lara, and we are the League of Rural Excellence, or LOR.
So, good morning and afternoon and welcome. So what is the opportunity that LOR is offering today or to solve? So like many businesses, rural healthcare organizations don't have a meaningful way to assess, evaluate, and act to improve performance. So before we know that we need an excellent website that helps us to have connections to other providers and colleagues, how do we know that we need to have joy in our workplace? How do we know that we need to implement a new technology? We need to be able to evaluate, act, and assess. Organizations need dialogue and they need a roadmap. This doesn't always happen in organizations. What do you need? You need to be able to assess. What do you need? What do you want to implement? What's the problem we're facing? Who are the stakeholders? Why do you do what you do? And how to evaluate your answers to act and improve on performance. Organizations have access to lots and lots, vast oceans of data and suggestions on how to improve, but how do they know internally what's important? Businesses would need to evaluate these key categories in their business, including leadership, strategy, customers, workforce, operations, and finance. And then what are your results and how do they integrate throughout each of the categories of your healthcare organization, tied together through measurement, analysis, and knowledge management. This image is from the Malcolm Baldrige Performance Excellence Program. So what is the solution? Improve performance by facilitating integration of evidence-based performance excellence programs within rural healthcare organizations so that they can better assess, evaluate, and act to improve performance. How do we do this? So LOR, the League of Excellence, has a business model which includes a key coordinator, I'll say, of care, someone who is acting on your behalf to coordinate resources once you've evaluated in your organization what it is you need. Who's going to pay for this? Payers might benefit from organizations evaluating and becoming more and more excellent. So you may find that becoming more efficient is a part of your evaluation. Payers are very interested in that. Reducing hospital administrations might come out of your evaluation. Payers are interested in that. The state is interested in healthy communities, so they're interested in strong organizations who have evaluated their business. And who would be activated by this? Boards of directors, community leaders interested in seeing their rural hospitals achieve greatness. And what is the retention value? Ongoing support of performance excellence with a group of resources that you're supporting your organization.
Okay, so we came up with this graphic, and it kind of helped us to understand that we've created this four-stage process. You have a person, a real person working at a real rural healthcare organization, and she's confused. She has software, she has data, she knows what their performance ratings are, but she doesn't know what to do, and no one in the organization does. So she hears about this survey that she can go online and take, and it lets her know where she stands. Within 24 hours, a real person from Montana calls and gets her commitment to participate in this program. At that point, an on-site assessment is scheduled. And that person goes in and does a thorough assessment to identify the real needs and gaps within the organization tied to the 7 criteria of performance mentioned before. So once they have an understanding of the gaps and the goals that the organization wants to set, she returns to the League of Rural Excellence and a plan of action is created. Once this plan of action is created, it's launched. We establish scorecards to help the organization measure whether or not they achieve the goals that they've set. And then there's a network of support from peers and other organizations. We're not talking about selling more software. We're not talking about generating more data. We're talking about connecting this organization with real people who can help her use the information that she already has. You get ongoing support, facilitation, reports, outcomes, and the goal in the end is maintenance. That's our show.
You may have mentioned this, but where does the money come from? Who pays? What is this return to the League of Rural Excellence? Is that an organization, or what is that?
Go ahead, this one. Okay.
So who pays? It could be a combination of payers who would see the benefit in organizations strengthening their operations, which could include financial operations. Again, this would be an evaluation of what are the tools that your business could implement, your healthcare organization, your healthcare business could implement to achieve efficiency, such as lean or rapid innovation models. So payers would be interested in the reduction in costs that might result from that. Also, state money might be available. Again, it's important for rural access hospitals and FQHCs to be strong. A healthy community is a strong community, and I think states and the federal government are very interested in that and improving social conditions, which this assessment would lead to, ideally.
I have 2 questions. And the first is, you talked about the sort of the online survey and then the on-site visit. Would you consider separating the 2 so that folks could just use the online survey and not follow up with the personal on-site visit?
Yes. So the online survey is free. It's just basically a snapshot of the 7 criteria of performance so that they get some sort of a visual representation. And actually, it's probably not going to be a surprise to many organizations. But the importance of then also getting the follow-up call is that even if you rank low in one area, in a small rural organization like Muskogee Hospital, they might not be able to target their lowest score. It might not be important to them, it might not be feasible, so they need real people to help them figure out what's important to you, which scores do you want to improve. So while they get that visual feedback, that's really not that helpful. It's like the other data that they have. Unless they have a plan of action, it's just numbers.
So my second question is going to go with that. First, I would challenge the free part of that because we're in an entrepreneurial setting. And so then my second part is the nonprofit part. Why a nonprofit? Why not a for-profit?
Well, it could be either. It really does depend. I think rural healthcare organizations are challenged by funding. And so if you're left with no funding and no support to improve, what does that mean for communities? Does that mean you go under eventually? So it's up to all of us, I think, in the healthcare community to make sure that performance excellence happens regardless of whether you're charging someone for it or not.
Thank you so much, Laura. Next up, we have Primary Care Montana. And Smart Care, we have you up on deck.
Is this on? Yeah, okay. Julie Fife.
I'm Tessa Zolnikov.
Tanis Hargrove.
Leslie Bartizono.
Akira Templeton.
And Eric Dietrich.
Okay. The problem that we're trying to address is that traditional methods of primary care physician recruitment and retention, it centers on policies that prioritize population size, and that often leaves rural communities without. National databases and strategies currently being used don't make Montana stand out. They don't convey relationships, community stories, or make the more balanced work and family life that make rural communities shine. They don't do that right now. Also, making primary care in Montana appealing and recruiting the right kind of provider is bigger than any one facility has resources to do. So our aim is to apply marketing strategies that have been used in other industries to rural health care, to attract and retain quality skilled providers to Montana communities. And so what we did is we looked at what has worked in other industries. Sorry. We're going to flip through that. We looked particularly at the tourism industry and the Get Lost campaign. And when they approached this campaign, they started with, well, there's nothing here. And how do we market nothing? How do we make that a weakness and flip it into a strength? And so instead of focusing on nothing, they focused on who would be attracted to nothing, and really targeted their customer. And the result of their campaign is that they had a 300% return on investment in 6 years. They took the non-resident tourist industry from $2.7 million to $3.2 million. And so we would like to apply that approach of selling a culture of primary care in Montana instead of making it a facility-only approach to recruitment to an industry approach.
Здравствуйте, comrades. All right, so very quickly, this is our problem. Traditional recruiting does not work. This is our product. Community-based recruitment strategy for human resource departments at healthcare centers serving rural Montana, blah, 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 right? That's what we're doing. This is a typical job ad. Isn't it amazing? Small town, rural facility. That is what physicians, clinicians are looking at. I mean, I would just look at this. Are you going to send this to your significant other and say, I found the most amazing job. It's in yellow, and this job is marked urgent because nobody wants it. Okay, right? It's ridiculous. And look at the salary. Pretty great salary, but it's urgent. That means nobody wants to go there. So our recruitment strategy is based on branding Montana culture and lifestyle. Yes, that is a cow. I think it is a milk cow, not a ranch cow, but anyway, you get the point. So this is our branding strategy. We have 5 principles. The people we want to recruit are not those that just want to pay off their student loans, even though that's a good incentive. We want to recruit different clinicians where when they think of principles of working in a rural community, they think of the community. Yes, it lacks money, but we make it up in other areas, such as relationships. Becoming this clinician in a rural community means that there is community leadership. You are going to be seen as a pillar of a community. The quality of life, cost of living. I'm from Roundup, Montana. You can buy a house in Roundup, Montana for $60,000. It's unbelievable. The environment in these types of communities, they are safe. They're safe. 1 minute left. So if you have families, that is a really great selling point. Pace of life. Whoa, Nellie, if you've ever been on a horse, right? So some people say that the pace of life in Montana in a rural community would be more slow, which is true, but I would also describe it as more rich, more wholesome, more healthy. Also, scope of practice. You get to do everything as a family practitioner. You get to do pediatrics, geriatrics, you get to do OBGYN, you get to do everything. That's amazing. This is what we want to rebrand this as. This is something like this. Practice where you play. Livingston, Montana, seeking physician. Practice at your own pace. White Sulphur Springs, Montana, seeking family physician. We need to change the way people look at our rural communities.
Can you guys describe the approach that you'll take? I mean, in my mind, I'm envisioning a Match.com website, but for rural health recruiting. I mean, seriously, that, you know, it's popped into my head. What a great idea. You match the right person with the right person or the right place. So do you guys have that kind of setup? Is that what you're going to do?
Yeah, sorry, last PowerPoint.
Okay.
So I guess I kind of saw it as a public-private relationship, maybe starting with the state. The state has funds that are kind of set aside for specifically for primary care recruitment activities. But then also having facilities invest in that and be a partner in that, some sort of match funding. And, you know, we just discussed in real general terms, but yeah.
Sorry, we also talked about having more media involvement and doing a little bit more of this idea of having the community share their stories and highlighting that on like a Match.com to really give providers an idea of what they're getting into and what kind of people live there and what kind of lifestyle they can expect when they get to Roundup or White Sulphur or Livingston. So really giving them that picture through media, videos, whatever that looks like. Oh, Nick, any other questions? Oh, you have a question?
And organizationally, kind of the setup we're thinking is kind of a consulting firm type thing here, where you kind of like have some people that get really good at helping communities kind of articulate this sort of idea and create media products that represent that well.
So the hospitals would come to you and say we want to buy. Yeah, ideally, yeah. Or we would be hopefully working with some of those recruiting dollars that they're already spending and not getting great results, and hopefully shifting that to us. Yeah.
Thank you so much, Primary Care Montana. Next up, Smart Care. And on deck we have Rural Mustangs, I believe. All right.
So this is Smart Care, and I'm Kate. This is Gary, Justin, and Kevin. And we're a bunch of professionals, well, a group of professionals, I guess. And we are interested in fixing medication therapy throughout that transition from the hospital to the home.
I'm trying to bring it down to a personal level because you or I or one of our aged loved ones at some point in time are going to be hospitalized. And most of us that come in take a medication, and the focus here is on medication management. And may come in with 5 or 6 different medications, may end up having some discontinued, new ones added on, or a change in dose. And so in the busy hustle bustle of a discharge, there's an opportunity for a lot of confusion because there's a lot of information being thrown at the patient in a very short period of time. Discharge has a connotation of a disconnect. It's kind of like thinking about a battery. And so we're trying to encourage, instead of that word, trying to encourage transition. Transition has a connotation of connect. And that connect then is the process we're looking at as to how to fix this so that the solution that we've designed is going to give the patient a follow-up and better care.
Before we go into the solution, though, we do want to let you chew on a couple numbers because they're pretty big. So if you can imagine this readmission cycle, this revolving door, really cuts into hospital as well as insurance company revenue. It has been reported that 11% of readmissions can be attributed specifically to medication non-adherence. And the total cost of medication non-adherence has been estimated to be $100 billion annually. That is a lot of money. So who's going to pay for that?
So let's look at what Smart Care does.
So SmartCare reduces the liability of the patients being readmitted back into the hospital within that 30-day period after being transitioned out of it. So the way they do that is through an integrated system, by providing an integrated health solution, by connecting hospitals, pharmacists with patients back at home, also including a mail order, incorporating a mail order pharmacy system, and our Smart Pill Box. So let's take a look at what exactly is the Smart Pill Box. The Smart Pill Box is a connected device, connected electronic pill dispensing device that provides the patient information about when they should take the medication, and which medication is appropriate for that dosage. So that information is also connected to SmartCare servers that provide information to our care coordinators, which feed back to the patient to make sure everything's okay. The main important part of the process here is connecting with the right online pharmacy distribution system. So we're going to go with PillPack, primarily because of their convenient dose packaging, which comes in 8 a.m. Monday, and that will conveniently fit into our existing Smart Pill Box. We also have, and so then we'll go into kind of like how it kind of looks. So we have Phil who's sick. Phil goes to the hospital. At the time of being released from the hospital, he's given his starter pack. He's also given the Smart Pill Box. At that time, the hospital lets SmartCare know that this is happening, contacts PillPack to make sure that Phil gets his medication in time. Also contacts our care coordinator, which we're going to reach out to a local pharmacist that's in town to make sure that Phil is using his starter pack and also knows that his pill pack is coming, and creating this nice little feedback loop. So looking at the device, it's pretty much, it's Wi-Fi, 3G, like hardline modem. It's connected. You have wearable applications, so a wristband if you don't have a smartphone, which provides alarm reminders. You have also proximity lock and unlock functions. And the device also comes with an override system, but the main importance is that connectivity back to the SmartCare services, which feeds back to the care coordinator, which leads back to the patient.
So the SmartCare services will provide an overall increase in the patient value. It improves patient health by simplifying the medication therapy process. It provides oversight and simplification in the transition of care from the hospital to home. It lowers the readmission rate, which increases hospital revenue by increasing reimbursement rates. It decreases future care and utilization management services by insurance company, with overall improvements in the rural health through the SmartCare services system. A significant improvement in the patient's health and happiness can be achieved.
So what questions do you have for us?
So I just want to make sure, I know you kind of explained it, but I want to make sure I'm clear on this. We know that a lot of people in rural don't necessarily have computers, but almost everybody has a cell phone. So you have the capability of doing this through a phone itself, or it has to be hardwired?
Yeah, so what we were thinking is creating a module piece where you can, depending on where the patient is, having Wi-Fi, 3G, or modem with landline connectivity. And so the box itself is the one that transmits to.
So you guys are going to create the app?
Create the app, or leverage existing technology to do that. Because all of this exists, it's just not put together.
Who is this care coordinator? Where is that person employed, paid?
So the way that works is it'd be a local pharmacist, because they're the ones dealing with the actual client, patient. And so the way we were thinking is, because you're taking the liability off of the hospitals, you contact a pharmacist who can act as consultants, or act as what pharmacists do, educating the patient on the drugs that they're receiving, and just help with that process. So you can, I believe we can still charge the MTM codes, and then they would be employers of SmartCare, and SmartCare would just bill insurance, bill that. And then because it's only because our model works with the 30-day period with hospitals, afterwards, insurance companies would love that, so insurance companies can pick that up.
So the pill pack or the pill box is somewhat of a piece of durable medical equipment, correct? Do they give that back after 30 days? Or is this something they buy, they purchase, insurance pays for? Or I'm just kind of thinking ahead here. And when you are being transitioned out of a hospital, it is a scary time, and a lot of people are already drugged up and nervous and everything else. The setup sounds like it will be a little difficult maybe for some people. So is there a way to walk them through it, or are you going to have some way to do that to ensure that they're doing some of that, some callbacks or something like that?
So one thing that didn't initially stand out was that within a 48-hour period, there would be an initiated phone call from a pharmacist, and that would happen like right after discharge, and that would answer any lingering questions the patient had about utilizing the smart pill box and any of the services, and any questions they had about their new medications or changes in doses. So that consult would be generated rapid, and that hopefully will capture a lot more patients. And then a couple other questions you had, one about the feasibility after the 30-day period. That's kind of what we had envisioned, like within that 30-day period, hospitals might be more interested in it, and then afterwards it would be insurance companies that are trying to reduce cost from having their patients in the hospital and stuff like that. So ideally the cost could transition for who would be paying for it.
Thank you so much, SmartCare. So next up, we have Little Mustangs? Wild Mustangs. And on deck, we've got Pioneering Partners for Children's Health. Fantastic, you guys, there. We'll start on you.
I'm John Raymeyer.
I'm Gina Berner.
Ready? Okay. Well, we started out as the Wild Mustangs, but we think we're now the last of the Mohicans in our group. So, and so because the Mohicans are somewhat of derived from a primitive culture, we have primitive audiovisuals. What we decided our problem was the bigger problem we began to address was that we have a shortage of healthcare providers of all different types in our rural communities. And one of the things that we know about that is that we know that healthcare professionals who tend to train in rural communities tend to stay in rural communities, and we also know that we have limited training opportunities in rural communities. So what we identified is that we have students coming out of academia or out of training programs, whether they be rad techs, whether they be physicians, whether they be PAs, whether they be registered nurses, LPNs, and all of these students have obligations to have clinical practice at various points in their education. So they're coming out of their schools and having to find clinical opportunities to practice in. And then they end up in the maze. They may or may not have connections to sites. They may have to find sites on their own. They may have somebody helping them, but basically it's an extremely overwhelming maze for them to negotiate their opportunities for clinical education. So what ends up happening in our state is we have some large urban sites that are easy targets. They have multiple services available, but the problem is that our larger facilities are being overwhelmed by a tide of students. They're oversaturated, and they're not having enough opportunities to meet the need for students. On the other hand, in various parts of our state, we have deserts. We have small critical access hospitals that are willing and open to be educational sites for students, but they don't know how to get connected to the students. And so our solution is what John is going to talk about.
So we envision a website similar to Match.com or FarmersOnly.com, where we have these two groups of people who are somewhat wallflowers. We have these rural providers who have opportunities, and we have these clinicians or these trainees that need opportunities. And this website would look similar to this, where if you would come into it, you as a student or a trainee, it would say I am, and then you would select the button to say I'm a PA student, and I'm looking for a certain type of training opportunity, and then it would populate the screen with a list of rural health care providers and facilities that meet that meet those criteria that you've laid forth for them. And so it's kind of like it's very similar to a dating service, though I've never been on one. And then for the facilities over here, it says I am a hospital or a clinic, and then and they have the capacity to be able to support these specific types of training opportunities. And then then the facilities would be able to reach out to students that meet their profile as well. Students very much like that kind of personal touch from a facility, and to get a phone call from someone inviting them to come train would be a meaningful overture to them. The business. Okay. The business model for this, we think. I've polled the 2 medical schools since this has started, and they said that they would pay between $50 and $100 per student for this kind of service, because they have a difficult time with matching, with having enough rotation sites for their students. So, and then also the facilities would pay a certain amount of money to be able to be on the site as well. But the educational institutions would see a lot of value in this, because it would open up more opportunities for their students, and it would also put students where they're needed most, which is part of almost all their missions.
Another opportunity we see for sustaining this model would be if you would go onto a Match.com site, you're going to see advertising. And we would limit the type of advertising to be that which would actually be a recruiting tool for facilities as potential, where they could put those beautiful pictures, like our colleagues so well showed, of beautiful opportunities in Montana, and have a picture of their site there and say, come here and do your clinical rotation. It becomes a marketing tool and a recruiting tool for the facilities, because so often those students will come back to practice there. So we see an opportunity for sustainability financially through that as well.
I believe that's all we have. Thank
you. Each clinical program has accreditation and other kinds of academic standards that have to be met by the trainers, by the training facility. How would you accomplish that part of the transaction to ensure that the students were going to some place where they were going to get a valuable education?
That would be the responsibility of the school to visit those sites that their students are going to. And so they would have to be, Henderson, or Methodist Hospital in Henderson is a training site for a medical school, and the school has to go out and make sure that those rotations are available and that it has that capacity. But still, the responsibility is going to fall on the school. This is a connectivity type a connector point. So it wouldn't take the place of any of those processes. Does that make sense?
Oh, yeah. Just that there's a new step in there.
Right. My question also is, so you're focusing only on students, not on any other type of recruitment. So it's essentially just the training component.
Health professionals, trainees.
Okay.
So your counterpart over there would do the recruitment.
Fantastic. Thank you. Thank you, Wild Mustangs. I like that. Checking willingness to pay. Great job. We have now pioneering partners for children's health. And we have our last presenter on deck. We Care, You Count.
I'm Tony Altenberg.
Roxanne Hovenkotter.
Cole White.
Shari Fott.
Richard Wurst.
I'm loud. I'm Anna Von Goren. And we are pioneering partners for children's health. Montana has a twofold problem. First, we've got a shortage of school nurses. In the state of Montana, we only had 3 of our counties that met the national standard for school health nursing. We have 1 nurse for every 750 students. The second thing we have going against us is we've got a lack of access to health care for our school children.
Currently, we have students who have great health needs. We have school nurses who are overworked, and we have a limited number. And we have primary care facilities who are a great resource. And when I talk about students, I also talk about parents. Communication is key. And right now, that communication is limited or non-existent. So how can we get primary health providers, parents, and schools to all communicate? In essence, we're talking about an electronic backpack.
And we want to improve access to care by some of our most vulnerable population, and we also want to increase the frequency that they have to preventive visits. Currently, 1/3 of all students in K through 8 don't receive an annual well child exam, and roughly 30%, according to the statistic I'm making up for this presentation, aren't fully immunized while in school. So currently, there's a lack of resources and the delivery, monitoring, and reporting of health and health-related services by school nurses. To overcome this issue, we're looking at reducing barriers between schools, parents, and primary care by improving the communication tool between these 3 entities. Currently, this process of communicating between school nurses, primary care, and parents is either not getting done, it's either being done very rudimentarily and infrequently, and that is usually done by a note going home to the parents in a backpack that, as anybody knows, usually doesn't make its way to the parent. So the solution to this is essentially producing a very micro health information exchange. As we know, most health care is delivered locally, and having a very small health information exchange between a school nurse and a community provider and a parent would be instrumental in improving the overall health and well-being of our children. And when we improve communication, everything improves. The health of the child improves, the delivery model improves, everything is lifted. So we do this by leveraging EMRs and IT. And when we can leverage electronic medical records and IT, health outcomes improve, and the profitability of schools improve because their overall costs go down, their sick days of their children go down, and the profitability of local providers goes up because their market share and market penetration improves.
So what our proposed solution is to use an electronic medical record, and we can start out small. And we could do this because we're the state of Montana, and I think our unofficial motto is we do more with less. So we do have, for instance, academic medical or academic centers that we can pull students and academics such as myself to go into communities, start out some pilots, and bring the stakeholders together, do some assessment, and figure out, do they already have a system in place, such as a critical access hospital? If so, great. If not, open software is available. How much would it cost? Because we're using existing resources, next to nothing.
So this is just a big slide that shows all of the things we could use this data for if it was all in one place. You know, it would just be great to be able to have a big pool of data to advocate for more school nurses, support grant writing initiatives, and all of the things that are already going on. Across the country, the National Association of School Nurses has an initiative, Step Up and Be Counted, where participating school nurses report in on Excel spreadsheets. We could make that easier for them to participate. The school nurses could track student health, promote follow-up care, connect students to other resources in their community, show this percentage of students in our community have this need. Let's bring in somebody who can provide that need. Chronic disease management, mental health screening management, concussion monitoring. There's so much that can be done when that information is accessible and you can find it.
And we see this as a multifaceted approach, but it has to have a common vision. And that vision then, if we can spread that to the students and get the parents on board, it should bring a mindfulness that is this holistic health care that we think will benefit in the long run. I mean, it's a start so that these children will see the importance of managing their health as we get everybody on board. And we keep this record to track them throughout.
So privacy is a big concern, particularly where kids are involved. How do you protect that?
Well, it's an EMR that would be already in place by a local clinic or a local hospital. So like anything, there's going to have to be certain documents exchanged between parents and school. Parents already have to sign away 1 million documents when they start putting children into this EMR. The great thing is probably half of them are already in the local primary care provider's EMR. Adding that other 50% of those students, it is already a robust system. It's encrypted software. You can restrict user access to individual medical records by need-to-know basis. So a school nurse would be limited to how much information she could see in that patient's medical record just by her level of use and utilization.
And it would help establish, parents have a hard time remembering what to ask their physician when they get there. And I think having that in a central location database would help that question be there when the parents went into their appointments.
The great part about how a lot of these local clinic softwares work is they do have a lot of electronic interfaces and a way to communicate that information to patients. So what used to be that note going home now becomes an email or a text message right off of that system by the school health nurse. You'll be able to say, your child needs an immunization, or your child needs an A1C, or your child needs this or that. It becomes an electronic background.
I was going to play the Bill Harley song down in the back. Sure we could integrate it with the talk.
Just one quick question. Have you thought about also incorporating in the local county health departments through that?
Yes.
Where most of those kiddos get their
Public
vaccines?
health nurse or public health department in each county would be the kind of the central, I think.
Our scope started out very large, how to integrate school nursing with primary care. And school nursing is just one facet. Why aren't home health nurses having access to, or home health or public health nurses having access to these EMRs? So their patients in certain parts of their health and health history can be logged because they're on a system that is now queryable and reportable. Yep.
Sorry, I may have missed this. So how do you, or do you try to address the shortage of school nurses?
I think that's hard. We got really mired down in just the sheer expanse of the state and the resources. If you go back to this map, I mean, yeah, in 2012, three Montana counties actually met that ratio, 1 to 750 students. And there are a good 26 states that don't have a school nurse, or 26 counties that don't have a school nurse. And I think that something like this could give that data piece.
And we only have 56 counties.
Oh, sorry, so 26, didn't I say 20? I don't know, 26 counties. So it feels like if we could start with that data piece, if you could show these students have needs that they're not being met, then there are bills that are being put into the legislature that are being sponsored by the Montana Association of School Nursing to increase the funding available for rural nurses. So hopefully that data piece could be a contributor of that.
And one school nurse could now more effectively take care of more children across borders as they're able to get in and look at those that information and transmit that information more effectively.
And we also discussed that the school nurse could be an arm or an outreach from a local medical facility, whether it's our Frontier Regional Health Center or a critical access hospital, and then that would it would be an advertisement for that hospital. So they could write that off, and you would draw patients then into that facility by doing the same thing.
And that's really where the financial benefit comes from. If a hospital and a school can integrate, it lowers their cost to provide school nursing, increases market share and market penetration. Everybody wins.
And it might help support some of our medical facilities, like Superior. They go out of business if we don't vote for the levy.
Thank you. Thank you, Pioneering Partners for Children's Health. Now we have our final presentation for today. Last but definitely not least, we have We Care, You Count.
Hi, I'm Michael Topchick.
Ken Wall.
Jordan Tenenbaum.
Stephanie Denning. And Deb Anzac. And we are We Care, You Count. We are looking at measuring and demonstrating the value of critical access hospitals to our customers.
Very briefly, we all understand how deeply under assault the rural health safety net is, whether it's policy or our patients out-migrating and leaving our communities, and why oftentimes that's a perceived value gap. And we're going to emphasize perceived. This map says it all. This is the operating margin of critical access hospitals across the country. Red and yellow are both negative margins. We see this as an opportunity to help invigorate the rural health safety net's value proposition. These are also our targeted first clients.
So the real problem is, even though that critical access hospitals, and there's evidence to show that they provide as good of quality, if not better, than PPS hospitals, they really are still struggling with showing value to their community and to their partners. One of the things the community may have a perception, just because we have low volumes, that we don't provide quality care, or that our statistical significance on the measurements and the current value measurements is not there. The current survey process and measurement process is very cumbersome, and it's very difficult for critical access hospitals to comply. So our solution is really moving healthcare into the 21st century and making the patient-centered and looking at customer feedback. And with We Care, You Count, it's a real-time point-of-service customer service satisfaction data collection platform. Some of the things we'd like to produce out of this is a low-cost cloud-based solution. It works with multiple devices. It provides a real-time dashboards, so feedback to the customer and to the employees using different devices, geo-mapping. It's customer-directed, user-friendly, using proven survey techniques and models, and really embracing social media. We believe that our solution is novel and disruptive to current technology. We have a demo to show you.
So if you imagine that if this is the critical access hospital rather than UM campus where we prototyped this morning, so you'd be looking at the floor plan of the hospital, filling out a survey, one question at a time. The patient would be able to answer additional questions if they wish, but they wouldn't be presented with all of them at first. These would be asynchronous, random sample, so that over time you could get a random sample statistically significant. They could also provide comments. They locate themselves by clicking locate on their phone or their tablet or their computer or on a kiosk or tablets passed around. These were done this morning with people completing the survey for us. We also have integrated social media into this, Flickr, Tweet, etc. So these are the social media sites that come up. We didn't want to click on any of these because these also include ones from campus from last night, so it's probably a little dangerous in this crowd. You can control it with a keyword search. I think the last person here said this nurse is really hot. So.
One of the things we hope to do is really kind of Yelpify healthcare, getting real feedback from our customers so that you can see the reviews, the current reviews, and their opinions. Really what our tool is, it's really a performance improvement tool to drive positive change, giving immediate feedback. Employees don't come to work, trying to do a bad job, but they need to know how they're doing to gauge that and to make those improvements. Really, we believe that our solution can be targeted to more than just healthcare and more than just critical access hospitals. We really want to drive that equation from volume-based to value-based.
So a novel and disruptive approach to community engagement requires a traditional and conservative business model. So we're using a flat licensing fee and subscription-based model to achieve this Yelp-like website and platform. There are opportunities for additional revenue streams, such as analytical support, predictive modeling, using the information that's acquired, as well as change management, implementation support in order to engage the new culture within the organization. So looking at the numbers, we in our extensive research, we figured out the startup cost would be about $550,000, charging, again, that licensing and subscription fee of about $1,000 per provider or $5,000 per hospital, looking at critical access hospitals. So again, taking a conservative approach to current competitors such as Press Ganey that can charge up to $60,000 a year. So in order for us to really be disruptive, we want to be conservative with our financial plan. Year one projected revenue is $1.5 million. And as of today, we have 2 investors and $312,000 in committed customers. No joke. So, thank you. Any questions?
I feel like we're in Shark Tank, which is cool. And I might have missed this. Where is your projected revenue coming from?
So we figured, the target market, there's about 1 million providers. Starting out looking at critical access hospitals, about 1,326 critical access hospitals. So, we use a relatively small percentage of that potential market to get to that first year number of 1.5 million.
It's cloud-based, so it's a subscription model.
Low startup costs too, right? There's another funding stream, which is if we look at per beneficiary per month and look at, instead of going to hospitals and providers, going to insurers, and we've had some of those conversations with Pioneer ACOs.
So patient satisfaction is a now federally measured metric associated with hospital reimbursement. And those survey mechanisms have to be have to meet certain standards in order to be able to be adapted by an individual institution. How do you fulfill that federal requirement?
So we're definitely going to borrow from the CAHPS survey, social science that you're referring to. We're not intending to be a CAHPS provider, but rather to sit on top of CAHPS and offer what is longed for by the provider community and by ACOs, which is to have real-time reviews. And that's the Yelpification we're talking about. So that for PI purposes, providers can make rapid cycle improvements based on real-time data. Consumers, we tend to be consumer-facing, can, just like when you go to Amazon and buy sunglasses, you look at the last 10 comments and how many stars for these traditional rural surveys.
And I think
so this would be a new cost because it's sit down on top of
right.
existing costs.
That's right.
Okay.
And then with the caps, that is kind of limited into the areas that they survey, HCAPS, for inpatient, potentially coming or ER. So really clinic provide and other outpatient services is a high potential.
We spent a lot of time talking about the rural value proposition in outpatient, ED, and in swing bed, and those would be the 3 areas we would target first.
And the real benefit to this over some of those types of surveys like CAHPS is the real time. You get immediate feedback. Some of those CAHPS surveys you don't get for 6 months. You can't make enough change to really change the needle on the next round. So the benefit of this is the real time.
And it might be screaming and kicking, but to bring providers into the 21st century so that there's that same type of feedback you would see in other industries with real customer feedback.
And we're simplifying the process so that the patient's actually answering one question that's a CAP-related question. Over time, it will aggregate enough data to make it statistically significant.
Thank you so much. We care, UConn. That was great. That went by really quickly. That was such good 9 presentations. Oh my goodness. You've come so far since yesterday morning from pitching. Those, I think, we had until maybe Q, so just around under 20 pitches to 9 great teams today. Give yourselves a big round of applause. Thank you so much. We're now going to invite the judges to leave the room and start their deliberation. There is lunch, and we're going to hold you back just a bit because we're going to give you a very short couple of slides, couple of minutes on what next. You've got great ideas, you've got great energy, you've got great teams. How can you continue this in the days and weeks ahead? So, judges, please. Oh, so first, while everything is still fresh in your mind and the judges don't have a chance to influence this, crowd favorite voting. We're going to vote, well, try not to vote for yourself. That's not quite fair. But other than that, vote for one of the 8 other teams that you think best presented, had a great problem, a great solution, and you really enjoyed their pitch. We're going to put this up for a couple of minutes. Then we're going to do our presentation, put this up again at the end. So you're not going to miss this even if we go forward from here. So 2 minutes here, and we're going to tell you what next.
All right, guys. Well, I have to admit that was as a spectator. I didn't have to present, but you guys did an amazing job. So just kind of going back to yesterday a little bit. We started probably 9:30 in the morning with a stack of blank pages lying on the ground and markers and a microphone, and to look at all the ideas that you generated and all the chaos, and to go from that to these presentations and real I think meaningful ways to make an impact in rural health is pretty amazing. So congratulations, good job. So one of our goals this week was to really turn you into entrepreneurial thinkers for how you can make an impact in rural health care. Here in Montana, 70% of the population lives in rural communities, which I'm sure you're aware of. And many of those communities have access issues to care. So with that in mind, it really only made sense that the nation's first rural healthcare hackathon started here. Yeah. Yeah, soon. 5 minutes. All right, so, but one of the things we want to touch on is it doesn't end here, and it doesn't end today. So before we part for lunch, we want to talk about some people who walked in your shoes, who came in here without having a clue of what to expect, and now they're running viable businesses. And then we have a couple of parting suggestions. So.
All right. I know everyone's going to lunch, so I'll keep this quick. A problem that some people have, and you may have experienced with your physician, is long waiting times. So I just want to give an example of how someone has gone from something systemic, a big problem, broken it down just as you have today, and more importantly, continued it on after the hackathon. Their pitch, they came up same as you yesterday. He said, my wife's worst days are when her patients don't show up. His wife is a pediatric physician. She goes through long days really trying to serve her patients the best she can, and when her patients can't show up, she can't serve as many patients as she wants to, and she gets really frustrated. So he asked, how can we solve this? And he found a team, same as you have this weekend, another engineer, a business person, a developer, and they figured out that data science was the way to solve this. Today, they are smart scheduling. And founding a company is just a piece of paper, not really something not by itself, something that's enviable. But what's great about smart scheduling is that they, with their data system that smartly, intelligently double books patients, they are now partnering Athena Health, which gives them access to 59,000 providers. So it's all of this weekend is really about moving forward, getting that scale. You've got great ideas. How can you move forward next and really make that impact in your communities?
So quickly, we want to play a little word association game. So I'm going to say a word, and I want you to think about the first image that comes to your mind. Entrepreneur. Man,
it's a tough crowd.
You guys are tough. All right. So as a society, we've really come to romanticize this idea of the lone entrepreneur, this heroic individual who, through savviness and hard work, can build a company and build an empire. But hopefully what we've demonstrated to you this weekend is that that's not true. Next slide. So in reality, it really takes a team of individuals, and a diverse team, if you really want to impact change and change both the healthcare and the community. So parting words, get with your team and figure out when you're going to connect next. Exchange emails, phone numbers, birthday cards, whatever it takes. And figure out also what holes that you still have on your team, and connect with everybody else in this room, because there aren't a lot of opportunities we're going to have such diverse viewpoints. Next. What story? All right, let's skip it. Cool.
So the next part is then, how do you get those customers? And you have great connections here. Really use the time after this to talk to them, validate, understand whether, already some of you have talked to potential customers, potential beneficiaries, potential stakeholders, and asked, is this something you would use? And I encourage you, as the momentum is high, as your team has energy next few weeks, to continue doing that and validating your model. So finally, I want to go back to what Dr. Terry Hills said on Friday evening. He talked about rural communities and rural healthcare being a bridge. And that bridge is from today, volume-based healthcare, to tomorrow, value-based healthcare, where you're talking about the care of the patient, wellness of the physician, and sustainability of your providers. So you've done a great job in helping to start bridge that gap. And we want to provide you with some resources to continue doing that. Blackstone Launchpad has generously provided their help. So if you have a University of Montana student, alum, or some other related staff or member on your team, you are eligible to seek help and potentially funding from Blackstone Launchpad. So come to us. We'll let you know how to contact them. And we'd like to invite you to our Grand Hack in April. MIT Hacking Medicine is holding what we think is America's largest health hackathon. We have 4 tracks, 40 mentors, 400 hackers, and approximately, and we've done the science and the math, 4 billion cups of coffee will be consumed that weekend. You've consumed some of that coffee yourself. So thank you so much for bearing with us, and we know we're holding you between now and lunch. Great job, everyone. Be back here in an hour at about 1:45, and at 1:45 right here we'll have the final announcements and the announcements of the prizes. Thank you so much for your time. All right, the results are in. Thank you so much for waiting. So the judges are moseying over here, and they'll get here in a couple of minutes. We just wanted to thank you for the great work you've done this weekend. You've really brought your passion, your energy, your ingenuity, your innovation here, and worked with others to come up with the great solutions that you pitched. And to end off with some closing remarks, just before we get to the prize giving and the judges will come in, it gives me great pleasure to invite the leader and the committee chair of the Organizing Committee for Rural Hacking Medicine, Monica Bourgeau. Monica, please.
So we've seen a tremendous amount of innovation this weekend. In fact, I'm just blown away. So I thought it would be appropriate to start with one of my favorite quotes from my absolute favorite innovator, Steve Jobs. And I think it's quite appropriate. Here's to the crazy ones, the misfits, the rebels, the troublemakers, the round pegs in the square holes, the ones who see things differently. They're not fond of rules. You can quote them, disagree with them, glorify or vilify them, but the only thing you can't do is ignore them, because they change things. They push the human race forward, and while some may see them as crazy ones, we see genius, because the ones who are crazy enough to think that they can change the world are the ones that do. So I want to thank all of you for being rebels this weekend. You were willing to put yourselves out there, and you allowed yourselves to look at things differently. You pitched ideas, discussed your frustrations, and worked to develop potential solutions. You worked with people from many different backgrounds and tried things you have never tried before. You were bold, you were brave, and most of all, you were amazing. I want to wrap this up with 5 challenges for each of you to take back with you after this event. And the first one is to reflect on this weekend and your experiences, and take at least one thing that you learned from this event. Take it back to your community, whether it's one of the solutions or a connection that you made here or a new piece of information that you learned. Reflect and take something back to your rural community. The second is to work with a diverse group. As you go back to your daily jobs and you begin to deal with the everyday problems that we encounter, remember the power of working with a diverse group and the power of bringing together different perspectives and different viewpoints to come up with new and unique solutions. The third is to stay connected. We've all made great connections here and possibly some new friends, so stay connected and continue to make new connections that will help you innovate in the future. The fourth is to be willing to fail. Not all innovations work the first time, and you're bound to fail. But allow yourself to fail, fail quickly, and get back up and try again. And lastly, be bold. While we're all making lots of incremental changes in healthcare, continue doing that, but don't be afraid to be bold. Healthcare needs some drastic changes right now, and it's going to take some of us to be bold to do that. So thank you to all of you. Thank you to our wonderful speakers, our awesome mentors, all of our amazing sponsors, and thoughtful judges, our tireless event team, and to our amazing friends from MIT. None of this would have been possible without all of you. So thank you very much.
Thank you so much, Monica. Monica and her team have worked tirelessly over the last couple of months. You should have been in the meetings with us where she just really, her great personality, the sunniness in her smile really moved us along as we found partners and sponsors. So I would love everyone to give another big round of applause to Monica and her team, please. So you know that the judges had a hard time, and thank you so much for waiting the extra half an hour while they came to a decision. Judges, would you like to say anything about, comments about the pitches you heard this morning?
All right. Well, didn't know I was going to be designated. Indeed, the time that it took us to deliberate was a reflection of the competitiveness of the presentations, the nature of the opportunities that we had to evaluate. First of all, I would say that each of these proposals has legs. That we have to hone down onto two is simply the task that we were given. But each of them has legs, and I hope that all the teams that were working on the individual proposals would continue to ferret them out and to find their applications. And with that, anybody else?
Fantastic. Thank you so much. Thank you so much to the judges. I know that was trying for you to be in that room and pick two winners, but they did it. So, first up, it gives me great pleasure to announce the crowd favorite, the team that you picked. And crowd favorite goes to Primary Care Montana. I'm looking forward to seeing prettier ads on my Google search box. All right. Thank you so much, Primary Care Montana. Oh, trophy! All right. In second place today, we have Smooth Moves. Great job. Finally, in first place, with this topping off this weekend, this 48 hours of pitching, of hacking, of working together, of iterating, really proud to present the winners. We Care, You Count. But really, prize or no prize, I hope you found this weekend different, enriching, that you've enlarged your networks and you're taking back connections that are going to help you and your community hack rural medicine. Thank you so much. You've been such great hackers, such great participants.